upload last lecture, did I? On Blackboard? I don't think I did because I didn't upload it to YouTube yet. All right, fever. So fever is a good thing. Um, everyone's so apprehensive about fever. You shouldn't be throwing, Tylenol or ibuprofen immediately when you see a fever. A fever is a good thing. The body is raising temperature through pyrogens. Pyrogens are stimulants that are released by white blood cells. There are exogenous pyrogens, so these are like bacteria and stuff, they can have it and stimulate our hypothalamus. So these pyrogens release, they go to hypothalamus, and that's what's going to stimulate fever. How do we increase body temperature? We pull the blood into the core, so we decrease those capillary sphincters, or we constrict them, and we raise metabolic rate. So they tend to go into a little bit of a hyperdrive. By doing so, by consuming ATP, you generate heat as a byproduct, and as you make ATP. So it increases that activity level of enzymes, white blood cells, all of that. So it's a good thing. You're consuming the nutrition inside your system so the organisms can't get to it. That's why we develop fever. By raising temperature, you also can denature proteins in the organism. So fever is a good thing. That being said, low-grade fever, so under 103.9 is a good fever. Above that, that's bad, right? Then you can have brain damage, stuff like that. So interferon interferes. So it's easier to explain with the image here. So you have cell number 1, cell number 2. A virus infects cell number 1. That cell produces interferon. Interferon is released into the environment of your body, goes to neighboring cells and tells them, hey, there's a virus on the prowl. If he enters you, don't let him use like your ribosomes. So it blocks it. So interferon, we have, a synthetic version we use for certain viruses or viral infections. I think Regeneron was the one used like during COVID. The problem with it is you infuse over several hours. It's several times a week. It's not a very viable method for dealing with infections from viruses. Made myself some coffee today. It is magical. All right. Complement. So these are proteins floating around in your plasma. They have different purposes. Okay. So when we look at complement, for us, we really just look at what activates it and 3 results from it being activated. So for us, we say there's classical and alternative pathways. So classical is antibody antigens. When these form, this triggers the complement cascade. And then the alternative is, it's also referred to as like the mannose lectin. So there are sugars that these patterns that can trigger it as well that are on like organisms. So all of them in the end, don't worry about like, the cascade pathway other than this is what activates it. And then what happens when we activate it. So the first thing is opsonization. Opsonization is we coat it with C3b. When we do that, it becomes very tasty looking to the phagocytes and they will want to eat it even more. So it's kind of like the analogy of like an apple is tasty, but if you put caramel on that apple, it's really tasty and everyone wants to eat it. Okay? It's the same logic there. We'll see the same process happening with antibodies. So opsonization is that increased phagocytosis because we're coating it with something that makes it more appetizing to the phagocytes. MAC, membrane attack complex. So this happens as well. What it does is the complex forms the different complements and punch holes into the organism. When they do that, they cannot maintain their environment, their homeostasis of fluid. Water rushes in, cell lysis. So now we have opsonization and MAC. That's our 2 so far. And then lastly is inflammation, enhancing inflammation. By doing so, we're opening up the capillary highways, the blood vessel highways, so the white blood cells can get in there and react. So it doesn't matter which way you start it, antigen antibody, or here they say spontaneous activation or like sugars activating it. The end result is the same. We get opsonization, we get MAC, we get inflammation. Okay? There are people that are deficient in this. You'll come across it. It's rare, but you can come across it. And they tend to have a lot of like bacterial infections. They can't deal with it. So this system is active in us all the time. They get like skin infections, stuff like that. It works even in that environment. So complement, it's circulating, it's inactive. We activate it. Once it's activated, we get MAC, we get inflammation, we get opsonization. Don't worry about that. Okay, immunity. So, or specific or adaptive immunity. There are two branches we're going to talk about. So I'm going to do this on the board and then we'll burn through the PowerPoint. So let me switch to camera. So immunity as a student was one of my favorite topics. I really enjoyed immunity. I think it's neat because when you understand immunity, a lot of things make sense in the body. Nope, nope. There we go. Let me turn on the light. I think that'll also help clear this up a little bit. Is it clearer now or are you getting glare? Like on the monitor? Okay. Sometimes we get glare. Depends on the classroom, really. All right. So, when we talk about immunity, there we go. We have to have some type of stimulant. So this could be a virus, right? So we have virus. He has an antigen on him. We have a bacterial cell. He has an antigen on him. We could do a vaccine. So vaccines could be destroyed virus or bacteria. So these are your killed vaccines. These are the ones you give to people because it's too risky to give them the live form. They can actually contract the illness. So I want to say Hep B. I'm pretty sure like Hep B is a killed vaccine. Yeah, because it's too risky to give them a live vaccine. We have live vaccines. They carry the risk of you contracting the illness. So like varicella zoster, chickenpox, MMR, measles, mumps, rubella. Those are live vaccines. They are risky that you catch the illness, but they elicit a stronger response. Your immune system is actually stronger from it. And now we have the mRNA vaccines. This is your COVID vaccines, SARS vaccines. This is probably the future of all vaccines. What it does, it gives you the code to build the antigen. You build the antigen, you develop antibodies to it. The beauty of it is no risk of contracting illness. The response is bigger because when we destroy it, we damage that structure sometimes and we don't elicit a very strong immune response. And then we can have haptens. Haptens are small little structures that can stimulate our immune system. This is where you get into allergies, for example, pollen, food allergies. They're so tiny, we kind of misidentify them as foreign and develop immunity against it. Same thing with viruses. Viruses are so tiny, and the vaccines that are for viruses that they can stimulate autoimmune response. We actually think a lot of autoimmune diseases are triggered by a viral infection. So, like for example, a buddy of mine, he got a bacterial infection, strep throat, and ended up losing his kidneys. Had to get a kidney transplant. Another friend of mine has type 1 diabetes. Thought is you got your cold, and then it misidentifies the beta cells in the pancreas and attacks them. And you end up with type 1 diabetes. Okay? So, the first thing we do is we have a phagocyte. And he is referenced as an APC, an antigen presenting cell. So this guy eats. He's got horns and stuff. All right. He eats one of these. And he presents it on MHC1. MHC2. My bad. Should be, well, could have just done that, right? MHC2. Is a complex, major histocompatibility complex. So what he's doing is he's destroying this or eating this and presenting the antigen. This is a crucial step. If this does not happen, or the patient has like defective phagocytes for some reason, they cannot stimulate the adaptive immune system. Who he's presenting it to is the CD4 cell, which is our T helper cell. This is another crucial step. If this guy is not trained, we cannot train the adaptive immune system, either lineage of it, okay? The humoral or cellular. We're stuck. So a little memory tool here is 2 times 4 equals 8. MHC2 communicates with CD4. Okay. When this happens, we immediately make memory CD4 for the future. So if we get exposed to the same organism again, they are ready. The system responds faster and bigger. Every time you do this, the system gets bigger and bigger and bigger. This is why we give multiple vaccinations or boosters. We're getting the system bigger and bigger and bigger. See, people don't, like a lot of times don't get that with vaccines, it doesn't mean an absolute that you will not catch the illness. You can still catch the illness, you can still carry the organism and transmit it and never even exhibit symptoms. All right. There really is no such thing as herd immunity. That's kind of a false reality. The thing is like as you get this system bigger, if you come into contact with the illness and you contract it, you can fight it very quickly and it doesn't take hold in your system and really beat you down, right? So a lot of people, like when they got like COVID vaccine and they still got COVID. I was one of those. I had three vaccines at that point. I still got COVID. But you know what? I didn't get put in the hospital. That's the difference. That's what we can't measure. How do you know that person was going to get very ill or not? All right. All right. Now this guy is trained. He's going to train 2 systems. The first one is the humoral. He's going to do it simultaneously, but the first one I talk about is humoral, right? So what he trains is the naive B cell. He becomes plasma cell. This guy makes antibodies. Okay. Simultaneously, he makes memory plasma cells for the future. When they check titers on you, say you move to a different state or different country, or when you're going to school, when you're going to your programs, they're going to check titers. Titers are a measurement of the amount of antibodies. What we're inferring from there is the amount of memory plasma cells. If you come into contact with, tetanus, are you going to be protected? You're going to have enough cells that will rapidly clone themselves, these memory cells, and dump enough antibodies into your body to protect you. That's what we're measuring. These theoretically should last a lifetime, but the body's lazy. If you're not exposed to that organism, you're not exposed to whatever that stimulant is, they'll wane over time. As we get older, the system wanes in general. So that's why you see a lot of vaccinations. We pushed until you're 50, 60 years old. We start giving them to you because you're at high risk then for how weak your immune system is, that you can't defend yourself. All right, so that's the humoral system. Over here is the cellular. Cellular, we train naive CD8, which is your cytotoxic cell. He becomes a trained CD8 or cytotoxic cell. He attacks infected cells. He will also make memory CD8 for the future. The infected cell will broadcast on MHC1 that he's infected. The CD8 will communicate with that and attack him and kill him. By killing him, he releases the virus or intracellular bacteria, which is kind of rare, but virus is more predominantly out. Now we can attack that directly, or it may have been killed in the process of killing him. So here, MHC1 communicates with with CD8, so 1 times 8 equals 8. How long does it take for this system to work? When you talk about antibodies, you can see that? Cool. Okay, antibodies, the first antibody you produce is IgM. This is a big structure. IgM is a horrible drawing, but IgM has 10 mounting points. Big old guy. Does not cross the placenta. Large structure. It takes about 2 weeks for that to happen. Then you produce IgG. IgG, small guy, can cross the placenta. This is your long-term immunity. This is the one that's going to protect you. Every time you get re-exposed, the baseline increases. That's where you're stacking in those boosters. That's why we give, Hep B vaccine 3 times. And we gap them at a certain point to elicit the immune system to respond and give us that bigger point. The CDC and WHO have done tons of studies on this, so they have these schedules for vaccinations. The thing that will drive you nuts when you get out there is the parent that comes in and goes, well, I'm going to give the vaccines, but I'm going to space them out because I think I know better than the CDC. Or I don't want to give pain to my child. It's too traumatic for him to give them multiple vaccines. One, their neural network most of the time when you're giving vaccines is non-existent. So in reality, they interpret pain for a very short period of time and then they forget it ever even happened. Secondly, you're still giving them the pain and now you're not going to give them the appropriate vaccination levels. Silly, okay? The 2-week mark, you're going to hear, oh, I got the flu shot and I still got the flu. Yeah, because you didn't take it early enough. That's what it comes down to. A buddy of mine was just telling me recently. Took his kid to get the flu shot, same day, kid got the flu. Didn't take it early enough. The flu shot is a dead vaccine. We don't catch the flu from that. There is a live version, but that's like your intranasal injection. Okay? Vaccinations are important. There are people where this system does not work. There is what is called severe combined immunodeficiency. This guy's broken, skid. It's broken. They can't make B and T cell lineages. The Bubble Boy, if you ever saw that movie, or there was another movie, I think it was like Everything is Everything, where the girl like is stuck in the house, she falls in love with the neighbor, that kind of thing. That is a true case. Okay? HIV attacks this. This is the cell that HIV infects and destroys. So if you take this out, what do you lose? This and this. You lose both. You lose both, you go back to the immunity of infant. Worse than infant. Why? Because mom, when you were in utero, you're in the as a fetus, mom is passing on IgG to you. That's why we vaccinate women when they're pregnant or right before pregnancy, because we want them to create this immunity that they can pass through the placenta to protect them. But HIV patients, they don't have that. So they're worse than that. So what do they die from? Like common cold, the least infection possible kind of thing, that our immune system would shrug at. Okay. So yeah, what's neat though, for SCID, severe combined immunodeficiency, we can actually cure it. We can rewrite their DNA and cure them. And how we do it is we take HIV, recode it, infect them with it. It goes, infects these cells, recodes them, rewrites their DNA, and heals them permanently. It's pretty wild that we can do that. Okay? I think that's pretty much everything. Yeah, cool. Any questions? Anyone at home? Do you need it for a second? Got it? All right. Switch back. So, humoral makes antibodies. B cells are B cells because they are trained a little bit in the bone marrow. T cells are T cells because they're trained in the thymus. That's where their name originates from. So B cells, when you make antibodies, they can interact with exogenous antigens. That means antigens on the surface. They can see that bacteria float in your bloodstream or the virus. The cell-mediated side deals with body cells, infected cells. So it's endogenous antigens. They're inside the cell, the infected cell. Okay. So as far as adaptive immune system goes, every time you get exposed to an antigen or a stimulant, you create this entire lineage for that one. It is antigen specific. It is one lock, one key. Okay. For every lock, we create a key. It's infinite. The more you train this system, the more you stimulate it, the stronger your immunity. One of the worst things we here in the US that we do is we're so sterile about everything. Everyone's walking around with hand sanitizer, freaking out about stuff. That's like the worst thing you can do. You want to stimulate this system as early as you can and give it as much variety as you can. Back in the day, pediatricians used to tell parents all the time, like, don't give your kid peanut butter till they're like 5 years old. Don't give them peanuts. And we discovered that's a big no-no. We are creating allergic reactions like wildfire. Now they tell the mom when the baby's a couple months old, like, you eat peanuts and go with your child, touch your child, stuff like that. Breastfeed them, stuff like that. Expose them to it, because those are those haptens that our immune system is starting to recognize and going, oh, that's foreign, because we haven't seen it. Okay? You always see, not always, but typically you see a couple things. If a parent has multiple children, the first child is the one that usually gets sick frequently. The second, third child, not as often. Why? Because the first child, they were fearing everything. Everything's gonna kill my baby. I got to take care of my baby, right? And so they shield them from everything. They're cleaning everything. They're boiling the bottles. They're just going crazy with it. The second child, they're like, "Oh, your pacifier fell. Here you go," and then back in their mouth. And they actually tell you do that. You drop the pacifier, put it in your mouth, put it back in their mouth, because you have bacteria in you. There is bacteria you're exposing them to. You're stimulating the system. Their immune system is stronger because of this. Immunological memory, that's what I was talking about. Like, this system should last a lifetime. You saw when they came out with like the COVID vaccine, they're like, "Oh, it's gonna last 2 months. Oh, it's lasting 4 months." And that was a CYA thing. They couldn't come out and say it should last a lifetime because they only studied it for that amount of time. They can't project it out further than that. So that's why they were saying that. Recognizes self and non-self. Every cell in your body has a name tag on it saying it's you, unless you're O negative blood type. That's the only one that doesn't. It is important that we recognize self so we don't attack self. When we misidentify self, that's autoimmune disease. We're attacking self because we think it's foreign, and we're very efficient at it. So this is where like immunosuppressive drugs come into play. We're turning down that system so that you don't damage your own tissue. Downside to that is you come into contact with organisms, you can't deal with them, or you may not be able to create immunity. So like my buddy that has the kidney transplant. So whenever you get an organ transplant, you're on an immunosuppressant drug. Period. There are other identifiers on there that even though we say you're a match, we're matching MHC, all of that, it's still foreign. Your body can still figure it out. We don't know why or how. We're not there yet in science. So they put you on immunosuppressive drugs. So my buddy, he qualified for like COVID vaccine, one of the first people because of his condition. When he got tested for antibodies, none. He can't generate them because of the immunosuppressant drugs. So this is why vaccinations are important. There is less chance of spread person to person if someone is vaccinated. So the problem is you got this whole anti-vaxxer movement. It is very silly that it exists, right? The guy that came out and said vaccines cause autism shortly thereafter came out. He published an article, and other scientists started questioning it because they couldn't find the same data and questioned it. And he came out and said he made it up. Made it completely up. But what happened? People took the information and ran with it. Bad science was let out, and it like destroyed our medical community a bit. It's kind of poor like knowledge. They even pulled, he was saying it's the mercury in the vaccines used as a preservative. They pulled it, no difference. See, autism is a disease of progression and then regression. They get to around age 4 or 5, and then they start going backwards. So they're developing and they start going backwards. Well, what happens around ages 4 and 5? Lots of vaccines. So he tried to do like a cause and effect and said, well, this is the reason because they're doing this at this age. It is not true. Okay. So yeah, bad science out there. The problem is there are people that cannot get vaccines, like my buddy. So the more you protect around him, yes, it's kind of herd immunity in the sense of if I catch a disease and the next 3 people between me and him are vaccinated, there's less chance of transmitting it through them and making it to him. There is that aspect. So yeah, important to vaccinate, right? And the downside, like I was just talking with my micro students, and we're talking about sequelae. That's where you get an infection, it remains in you and causes disease down the road. So like chickenpox, you get chickenpox, or if you got the chickenpox vaccine because it's a live vaccine, you get to have shingles down the road. That's sequelae. One of the big ones is SSPE, subacute sclerosing panencephalitis. If you catch the measles, you have a risk of developing it somewhere between 6 to 10 years later, and it's a death sentence. When it happens, the kid dies. And you hear, like, a couple of years ago, they were talking about there was like 10 or 12 cases of measles outbreak at Disney. That's 10 or 12 kids that just may die one day because their parents thought not vaccinating them was a good thing, right? Get your vaccines, people. All right. MHC, any cell that has a nucleus can produce MHC1. It's a protein structure, sugary protein, glycoprotein. So the only cells that can't are red blood cells. Any cell has the ability. So that's why when patients catch malaria, which infects red blood cells, they can't clear it because they cannot present on MHC1. The CD8 cell can't see it, can't kill it. You can't self-clear malaria. MHC2, any macrophage. So your book tries to say that, like, or sorry, not any phagocyte. Your book says like only certain cells are phagocytes. In reality, all your white blood cells have that ability. So white blood cells can produce MHC1 and MHC2. So here we're looking at an endogenous antigen. Something infected this cell. They destroy it. They then produce MHC1, mount it, and project it on the outside. CD8 cell can now see this. It can destroy this cell and deal with it. So the non-specific, this is just talking about phagocytes and that they produce MHC2. They eat stuff, break it up, and then present on MHC2 so that the T helper CD4 cell can see it. If your phagocytes are defective or CD4 are defective, you can't produce either side of the system. You lose humoral and cellular. Both are crucial for your adaptive immune system. So here we have the phagocyte. He ate something. He creates a phagosome, fuses a lysosome with it. That's a phagolysosome, destroys it, makes MHC2, mounts the antigen on it, and presents it. Sorry, Natalie, I just saw your chat. Was it the board was blurry for you? At the end of class, I'll go back to it, okay? We'll get it clear. I didn't have the chat pulled up. My bad. So here, this is basically what I did on the board, okay? Foreign body, phagocyte, eats it, presents on MHC2, trains CD4, CD4 trains B cell, becomes plasma cell, which makes antibodies. There's your humoral. CD4 trains cytotoxic T cell, becomes active or trained CD8 cell, attacks cells that present on MHC1. Simultaneously, we make clones. We make clones. We make clones for the future. So every time you get exposed to an organism, your immune system gets bigger and bigger and bigger, stronger and stronger and stronger. I mean, you always talk to people that are like, they immigrate from overseas somewhere, they like barely get sick because they're exposed to stuff all the time. Versus us, you know, born and raised here in the US, and you go to Mexico and you're dying, right? It's just we're not used to those organisms. I remember as a kid, I go to Egypt and my cousins and stuff, they're drinking tap water. If I sniff tap water, King Tut's revenge is going down, right? Our immune system just isn't exposed to it. It's not trained to it. So that's the problem there. So the more you expose, the better. I always tell my micro students, by the end of taking micro, you're going to leave with one of two mentalities. Either you're going to fear everything, or you're going to accept how strong your immune system is, and you're going to be licking doorknobs, right? Another prime example of this is my wife's niece and my niece. My wife's niece was born November 2019. She was born and we went into COVID. My niece, she's turning 2 in bad uncle in a couple weeks here, okay? Yeah, end of March 23rd, 24th, March 24th. There you go. Good uncle. So, um, my brother-in-law is a physician. He lets her get exposed to everything. He knows the benefit of stimulating this system. My wife's brother-in-law, he is a germaphobe. So their kid's born and they're sitting at home, and I kid you not, I'm sitting there and he is wiping down doorknobs and no one has left the house. Groceries come into the house, he's wiping them down. This kid now, we get out of the pandemic, kid goes to daycare, she is sick all the time. All the time, till now. She just gets sick by the weakest thing because her system is lagging compared to how kids are usually exposed to stuff. My niece, never sick. Never. They let her crawl everywhere. They have a dog. She is playing with the dog. There is literally video of she's eating her snack and she like tastes it and then she goes to the dog, lets the dog lick it, and then puts it back in her mouth. It's gross. But her immune system is stellar because of that. It's exposure. The more you expose yourself, the stronger your immune system. And it becomes of concern when you get older. A lot of physicians, they were very weary of during the pandemic of us going overboard with killing stuff. It's too much. And sure enough, that's what we're seeing now. And now think about this group when they get older. They live with this mentality of fear of organisms. They don't stimulate the system. When they get older, we're going to see a lot of old, sick people. Okay, becoming very sick from organisms because they did not stimulate it, right? So T helper, remember, communicates with MHC4. They're communicating through what are called T cell receptors. So on his surface, that's what's mating with the MHC2. And they're going to communicate with untrained B cells naive B cells, naive CD8 through chemokines or cytokines. These are just chemical communicators. So when you guys look at white blood cells in lab and we say that's a lymphocyte, you don't know if that lymphocyte is an NK, natural killer cell, a CD4, a CD8, a B cell. They all look the same. The difference is when you do further analysis, in a lab, we can see the markers on there. That's how we differentiate them, right? So CD4, he's the middleman. He's training both systems. HIV targets that. As CD4 counts drop in an HIV patient, they go to AIDS. As they drop, they shift into different categories on what they become ill from. So we have to proactively maintain CD4 count. It is crucial that we maintain CD4 count. My wife was telling me one missed dose of your HIV meds and the HIV can mutate and the meds be useless. One missed dose. That's all it takes. Right? So getting these patients on their meds, maintaining CD4 count, and they can live a normal life, no problem. Here they're showing T helper communicating with the APC and then through chemicals training the CD8. APCs can also produce MHC1. So if an APC is infected, which happens sometimes, the CD8 can kill it. So like EBV, Epstein-Barr virus, for example, infects your B cells. That's mono. You have what's called a civil war in your body. The B cells are being attacked by the CD8, and they're just fighting it out. And here they're showing CD4 or T helper cell training the B cell to become a plasma cell and produce antibodies. So that's just the images we looked at. Cellular immunity, remember, that is the T cytotoxic cell or CD8 cell. That is going to deal with endogenous antigens, stuff inside of cells. It communicates with MHC1. How does it kill? Heme and NK cells work the same way. They release perforins. I think we have, here we go. Yeah. They release perforins. Perforins perforate. They create a pore in the cell. Then they release granozymes. Granozymes are chemical communicators that enter the cell and go to the nucleus of the infected cell. What it commands the infected cell to do is pretty wild. It tells it, open up your lysosomes. Lysozyme is inside the lysosomes. It destroys the cell. It is referred to as apoptosis, that is the proper name for it, or cell suicide, commanded cell suicide. So we do this, you did this as a fetus. You had webbing between your fingers, your toes. You did apoptosis then. Right? So here they're showing APC and CD4 cell communicating. Here, and then here they're showing training the CD8 cell and then them attacking, cloning themselves to attack more. So when you get sick and your lymph nodes swell, that's what happened. You rapidly cloned all these cells. These memory cells clone themselves. When you get reinfected with something or re-expose something, that's what happens. Rapid clonal expansion. That's why you feel fatigued. A lot of times when you're sick, that's what happens. You feel fatigued. And so the reason is your metabolic activity is increased on these cells and it's just consuming nutrition like wildfire. Hence, fatigue. So humoral immunity, remember, B cell is trained, becomes plasma cell. Those produce antibodies. So that's what they're showing here. I looked at that image. So it's training the B cell. Plasma cells are your activated B cell. They make antibodies. Lots of rough ER because they are producing proteins. Antibodies are a protein structure. The more antibodies, the better. Downside is it increases blood viscosity. If you guys remember, the Johnson & Johnson vaccine for COVID, women were throwing blood clots. Women, because of estrogen, create more clotting factors. You throw in smoking, increased risk of clots. That vaccine, for some reason, triggered a high production of antibodies. It was one dose and that's it. So it's producing the level that's needed all at once. Increased blood viscosity, clots. Not surprising. Okay. So here, there's our stimulant. So antigen, we train, we create memory cells, and we create active cells. There's the antibodies. The second time you get sick, because they're trained, rapid clonal expansion, response. So the first time, you shouldn't have a big old response or a fast response, the first exposure. Second exposure, yes. Same thing with allergies. You technically cannot have an allergic reaction the first time on exposure. The reason I say technically is because of haptens. You come into contact with a hapten, it looks similar to something else, then you go consume or have that vaccine, that's something else, and you have a reaction your first exposure. Okay? There was something else I was going to say. I blanked. It'll come to me. So here, APC, CD4, training B cell, antibodies. What do antibodies do? Couple things. They mate with the antigen. Okay? That mating is important. So this is the variable region of an antibody. Antigen binding site is variable. Why is it variable? Because it changes according to the antigen it's trained to. The fixed or heavy chain region, the root here, the FC FC. I'm blanking. FC. Should be FC. Is what our white blood cells can see. So, one, if they bind to a virus, they can deactivate it. They can block it from entering your cells. Two, opsonization. That increase want to phagocytize. Three, they activate complement. All right. Antibody immunity. So this is the same thing we've been looking at. I'll just click through. Oh, I thought there was more. Maybe there's more at the end. Somewhere in there, there's more. Okay. So T helper cell member, both humoral and cellular. You take him out, we're in big trouble. Remember, he meets with MHC2. Trains both through chemicals, cytokines. Remember, HIV destroys him. So if we take him out, we lose both lineages. Looked at that. Antibodies. So when they measure it in your plasma, that's titers. That's what they're measuring. There's 5 that we talk about: IgG, M, E, A, and D. So IgM is the first produced. He's the big guy. He can bind 10 antigens because he has 10 binding sites. Cannot cross the placenta. He's indicative of when you take a titer on a patient and you see IgM, that means they either currently have the infection or they recently had the infection or recently were vaccinated. That's when we see IgM levels high. IgA is in all bodily fluids. So like Peyer's patches that we talked about, they're producing IgA, dumping it into your ileum. IgD, there's just thought that it helps with response speed. We really don't know what IgD does. IgG, that is your long-term immunity. That is the one that crosses the placenta. That's why we vaccinate the mother, to protect the baby. And then IgE, these are mounted on your mast cells and basophils and eosinophils. When they're trained and they have that mounted in them, the next time you're exposed to that stimulant, they degranulate. But they release heparin, histamine. There's your allergic reactions. There's your pollen allergies. That's what's happening then. So, once these are trained, they're pretty much trained for life. That's why we want to expose stuff to the child so they realize it's part of their environment. That being said, you can develop allergies down the road. Usually it's due to a hapten situation, smaller virus. You've been eating peanuts your whole life and you start to become allergic to peanuts. It happens. Shellfish. All right. The reason is your body misidentified something else. It looks similar. Now it thinks this is bad. And you're stuck. Shellfish and fish allergies actually may not be a legitimate allergy sometimes. They carry histamine in them. And we consume the histamine and it enters into us and it causes that allergic reaction situation. So, what about desensitization? Desensitization is where we give you micro amounts of whatever the stimulant is that you're allergic to, and we degranulate the cells methodically in a controlled manner. And we climb up in the dose we're giving you to the point where you are no longer allergic as long as you're taking the desensitization agent. Second a patient comes off of it, they start all over. There are times when you have to desensitize patients. For example, syphilis. The only way to treat syphilis is penicillin. People have penicillin allergies. So they'll admit them into the hospital and they go through the whole protocol of administering slowly over time to where they can give them the full dose of penicillin and treat them. It takes quite a few days to do, right? My wife had a patient recently. They were in there. I think she told me it was something like 12 kids, pregnant and has syphilis. And the problem is syphilis crosses the placenta and just destroys the child. So it needs to be treated. This chick left AMA against medical advice. Why? She didn't like the hospital food. left for like 2, 3 days, came back. And they're like, we have to start all over again. She didn't care. What are you gonna do? She was also a drug addict. I don't think it was the food. Right? Wild cases you'll see. So IgE, that's the antibodies. Remember, mast cell, basophil, and eosinophils should be thrown in there. Right? All right, types of immunity. Active and passive. Active means you're making antibodies. You're actively doing it. You are producing them. Passive, you just received antibodies somehow. Okay? Natural active is you catch chickenpox and develop antibodies. You caught it from your environment, you make antibodies. Artificial active is you go to the doctor and they give you a vaccination for chickenpox. You still develop antibodies, but it's considered artificial because it's medically induced. We gave you a vaccine so that you produce your own antibodies. Natural passive, when your mom was pregnant with you, she caught chickenpox and her antibodies crossed the placenta and into your bloodstream and protected you. You do not produce antibodies. About 6 months after birth, those antibodies will be gone. You would need to be vaccinated or exposed to that organism to create your own antibodies. Okay? So natural passive, the only way to get them is from the mother. Either they cross the placenta or breastfeeding. IgM is in colostrum, milk, mother's milk. So that's why they encourage breastfeeding. The baby can tolerate, or the baby can acquire the antibodies from there because they don't really produce stomach acid. They don't really have bacteria that can attack it in their gut yet. Okay? I was watching something pretty wild on Netflix, and it was about breast milk. And people will donate it because sometimes like mom dies or kid goes up for adoption, stuff like that, or mom's incarcerated. So there are situations where they have these milk banks, and so people will donate to it their own breast milk for it to be used for those kind of children. But it's kind of interesting, like these people that were on there, and they're like, one guy was a bodybuilder or wanted to be a bodybuilder, and he was buying some lady's breast milk because he thought that protein was so much better and that structure, the immunity in there was so much better, and he convinced himself of it. Your body doesn't care. Amino acids are amino acids. Proteins are proteins, right? But yeah, cuckoo for Cocoa Puffs, right? What else? Oh yeah, like so extended breastfeeding is kind of pointless. Once the baby starts to develop that acid in their stomach, stuff like that, the immunity protection disappears. Like you cannot pass it on. Okay? We had So there are lactation experts. These are people that are trained, they teach mothers like how to get the baby to latch, stuff like that. And I was on my peds rotation, and this lady came into a lactation expert, and she's, talking to my preceptor and us about lactation techniques, stuff like that, so we can educate patients. And she's like, okay, so milk outside, like in a bottle, unrefrigerated is good. I think it was like 3 hours. In a fridge, 3 days. In the freezer, I think she said 3 months. And my preceptor, she was like, I mean, what do you do if you stop like giving the child breast milk? What do you do with all that stored breast milk, that's in the freezer since you can store it so long? What do you recommend? And I think she was trying to get at like, how do you donate it? That's what she was getting at, because it's donatable at that point. This lady responded, she goes, well, if you have older children, stuff like that, you could put it in their cereal or, in your partner's coffee. Oh, I'm a hard pass on that one. Right? I was like, right? Pretty wild. Anywho, um, uh, the other issue with all of that is breast milk can carry disease. So any bodily secretion, certain diseases can be transmitted in it. So Like this guy that's buying some random lady's breast milk is dangerous. Okay? And then lastly, artificial passive. This is anti-venom. That's the best way to to tell you or explain it. We are just giving you antibodies in the moment. We have antibodies for rabies. We have antibodies for snakes, tetanus. It binds the toxin and disables the toxin. You do not produce antibodies. You do not have immunity after that to it. You go get bitten by a snake again, you're in a world of hurt again. Okay? The way they produce them, they inject small amounts into animals of whatever that organism is, and then they harvest the antibodies from them and inject it into us. So typically, like, anti-venom is made through using horses. That's usually what they use because they're such a big animal, and they put tiny bits of venom into them, and then they extract their blood and spin it down and remove the antibodies that way. And that's why, like, you always tell patients, like, or people, like, if you get bitten by a snake, don't bring in the snake. We don't need the snake, because the antivenom that's generated for your area has all the known poisonous snakes in your area. That's why it's illegal to have poisonous snakes as pets. And interestingly enough, they store that antivenom at the airport. It's at Hartsfield-Jackson. So when they have someone come in, they call them, they flight it in immediately to the hospital so they can give it to them if need be. Brother-in-law, he sent me a picture one day. He's like, look what these residents are doing. Some guy got bitten by a snake. He brought it in after he chopped it in 3 and burnt it. And the residents are on the ground trying to figure out what kind of snake it is. They were just sending him on a little wild goose chase for no reason. But yeah, don't need to bring in the snake. Okay? So here it's just a chart breaking down these guys. Remember who is who, if you're producing antibodies or not. We have a whole nother day to cover this. What slide am I? Oh man, you're really ahead. Okay, we'll just keep chugging along. Autoimmune diseases. So this is the body misidentifying your cells. There are tons of autoimmune diseases. It's just like a little sampling. So Graves' disease, this is targeting your thyroid hormone and overstimulating it. The antibodies are actually striking it and stimulating the production of thyroid hormone. So their metabolism is super accelerated. They don't tolerate heat well. You may have seen recently on TV, they advertised thyroid eye disease, or TED. They deposit a mucopolysaccharide. It's a sugary protein depositing behind the eyes, and it slowly pushes the eyes out of the head. So there are medications to reduce that. When we test for autoimmune diseases, we're looking for those specific antibodies. So that's what is on the right side here. Just because someone has the antibodies doesn't necessarily mean they have the disease. You can sometimes find antibodies, does not mean they have active disease. Okay. For example, I tested positive for SLE antibodies. Lupus. Don't have lupus. Just random production. Right? For some reason, I'm producing them. Right? That was years ago that I tested positive for that. Hashimoto's, this is hypothyroidism. This is destruction of the thyroid tissue. Type 1 diabetes, they don't produce insulin. Good pastures is a disease of lungs. And there's Wegener's, which is lungs and kidney. Lungs and liver. Lungs and liver. You'll come across it sometimes. The disease there, it destroys the elastic and collagen fibers in the lungs, and they develop COPD. They die from it typically, and then it also shoots the liver. So it's interesting. My wife came home one day and she's like, you won't believe this case we had. The guy listed that he's allergic to Tylenol. No one's allergic to Tylenol. That's so ultra rare. And was like very adamant about it. And then she's like, come to find out, he's got Wegener's. Because of the assault on his liver, they're told not to consume Tylenol. And that's why he lists it as an allergy. It's pretty neat. Okay. Pernicious anemia, that takes out the intrinsic factor production from your parietal cells. They don't bind B12. They have a macrocytic anemia. The red blood cells are all huge, not very functional. Primary biliary cirrhosis, this attacks the liver and their ability to produce proper bile. Myasthenia gravis, this is a neat one. It attacks the receptors for acetylcholine. They can't contract muscles properly. They usually die from diaphragm being paralyzed. I saw a case. The dad had myasthenia gravis. The little girl that was about 3 or 4 had myasthenia gravis. There's some genetic component there, which is pretty wild. So with them, their like eyelids droop, stuff like that. That's how you might spot it. They fatigue so easily. Tough. Usually adults come in usually you see it as an adult disease. It's pretty rare to see a child one, but they'll come in and they'll say like, I can't open doors towards the end of the day. Stuff like that will fatigue first their hands. They can't turn the knob, right? Dermato and poliomyositis, this is a destruction of muscle. The dermato carries a skin component in it. They usually have like real dark circles under their eyes, and it attacks big joints like the shoulders and the hip, stuff like that. So they'll say like, I can't get out of a chair. I feel like I can't get up. I don't have the strength. Vasculitis, there's a bunch of these. It attacks vessels. That's what it takes out, destroys them. Rheumatoid, you're going to see a lot of rheumatoid. Rheumatoid's very common. My father-in-law has rheumatoid. So there's destruction of the joints. If they do not treat it, they'll develop what are called like swan fingers. Their fingers will distort, completely twist like that. So they have to prevent it. So he takes Humira. He has to inject Humira weekly. The downside to that is that's an immunosuppressive drug. He's at risk of catching things. And you'll notice on all of those drugs, when they advertise them, Cosentyx, all of those, that you must be tested for TB before you take them. Cannot stress that enough, because TB, if you have it, it can be dormant. It's locked down by your immune system. And the second you take Humira, it will explode in growth. My wife had a patient recently. The physician did not check them, put them on an immunosuppressant drug, and they had miliary TB. That's where it's in your bloodstream. That's like a death sentence. I don't think the patient survived. That is a huge malpractice situation. Okay. MCTD is like mixed connective tissue disease. It attacks different tissues, all kinds of deficits there. Scleroderma also attacks tissue. Their face tightens up. There's a couple different ones with that. Under the vasculitis, there's one that you'll also see called Raynaud's. Their vessels in their fingers spasm in the cold, and their fingertips turn white and blue on exposure to cold. So we give them calcium channel blockers to deal with it. But yeah, tons of autoimmune diseases. So in PathPhys, this is like, the detail we go into, what I was explaining here, and how to identify diseases, what's the disease state, stuff like that. That's malar rash. That's what happens with lupus. And a lot of times when you study these diseases, they'll say like certain populations, this is more common to see. So typically we say, Caucasian females, we see SLE. That's the most common group you see it in. It doesn't mean it's only in that group. I remember I had a student, she was African American, her sister had lupus. Okay. And then on the bottom there, that's rheumatoid arthritis. That's that swan fingering that you see with the destruction of the joint. Every time they have a flare-up, permanent damage. With any autoimmune disease, that's really what happens. Every time there's a flare-up, permanent damage. So lupus, they lose their kidneys. There's also like MS, multiple sclerosis. Every time they have a flare-up, there is myelin destruction. Every time. But so as long as you prevent flare-ups or prevent disease pop-ups, you stop the disease progression. Right? So that's why we're very aggressive with that. All right. Well, that was the last slide. we moved along. Even though we missed a day, we caught up and ahead. So we're supposed to, just looking at the schedule real quick. Man, we are really ahead. So here's what we'll do. Let's not meet Monday, study, okay, for Monday, and then we'll meet Wednesday and just do review. All right. So yeah, study. We won't meet Monday, and then we'll meet Wednesday for review. And then let me pull up the camera to try and get it to clear up for you. Sometimes it. There we go. Can you see it better? There we go. Oops. All right. Hopefully you can see it clear, Natalie. If not, I'm going to leave it on the board. If you're on campus, just come in 110 and it's up here. All right? Enjoy your weekend. Study for your exams. And I'll see you guys Wednesday. Bye.